All right, there's our animal for the night. We're switching from dogs to elephants for one night and one night only. And this will be an ongoing reference to the elephant in the room. So the elephant in the room at the beginning of this discussion is just in the world of substance use, what's going on with other issues that people are struggling with, in particular trauma and PTSD. So this is stuff that we've walked through before in previous trainings. It's prevalence of substance use, and all this shakes out to in the ballpark of 6 to 8% of the population at any given time, the adult population, being diagnosable with a substance use disorder, which, as I always say, is really bad. Being able to qualify for a substance use disorder is hard. Things have to be going pretty poorly for that to be true. And what is a little bit changed, this slide, which we had data from 2013, 2014, used to be in the 90% zone. It's coming down a little bit. People who have that diagnosis but who were not in treatment. So it used to be an average of like high 80s, low 90s, and now it's, average of mid 80s, something like that, probably high 80s. But so that's a good thing. No, I'm sorry. That's a slight change on a very bad thing. That's what that is. So I mischaracterized that. Still, predominant share of people are not actually getting any kind of formal help. And then we have trauma and PTSD. So this is a bunch of childhood kind of statistics, mostly, which are fairly gruesome. And these are not PTSD statistics. These are traumatic events statistics. 1 in 7 children have experienced abuse or neglect in the past year, which, as we're saying here, is probably an underestimate. Quarter of kids will witness or experience a traumatic event before age of 4. Adolescents, if you take the age group between 14 and 17, 28% would have had sexual victimization experiences, including rape, 8% of girls. 2/3 of American children experience at least one traumatic event by 16, and 1 in 5 under the age of 18 experience sexual abuse in females, and 1 in 20 in males. And then if we look at prevalence of diagnostically, what that turns into, again, we'll walk through this in a minute, but most of that experience does not turn into PTSD. But if you look across the board at lifetime prevalence of PTSD, the percents you see there are 5 to 6% for men and 10 to 14% for women. And in that sense, it's a rival or slightly exceeds the prevalence of substance use disorder, which is a little bit shocking. And this is the type of interpersonal type of trauma we're talking about that you can that you're assessing when you're talking about causal agents for PTSD. There's interpersonal trauma of all sorts of categories: partner violence, childhood, physical, sexual, emotional abuse, sexual violence, victimization from strangers, community violence, witnessed violence, and then non-interpersonal violence, which would be things like natural disasters, motor vehicle accidents. Combat which is an odd non-interpersonal trauma. It's not considered a interpersonal betrayal, but it's an odd category because it's war where you're killing other human beings, and that's it's just an odd category. So if we step back to before the PTSD part of this, and we just talk about what are we talking about when we're saying trauma, lots of things, bad things happen, but the trauma that we're talking about in the developmental path to PTSD are ones that have a lasting effect when I've experienced something incredibly stressful or a series of circumstances that have been incredibly stressful. The formal diagnosis we'll get to in a minute. So often you have things like neglect, which don't qualify as a trauma formally for the DSM-5 PTSD diagnosis. Sometimes it does anyway, because if neglect is bad enough, it is considered life-threatening or thought to be life-threatening by the victim. But the trauma is typically then experienced by the person as a sense of overwhelming fear and aloneness in that experience. And in terms of the trajectory, that list of traumatic experiences that people have gone through, most of those don't turn into ongoing functional impairment, that I'm doing worse in my life. And it's thought that the range of causality is like in the 6 to 12% zone from traumatic events defined in this way. And then when you look at, well, why does one person get PTSD and another person doesn't? Again, this is not stuff that is completely nailed down, but there are a variety of variables that have been looked at that are related. So here's a list of the sort of the top ones that are relevant in whether this is going to be a progression from traumatic event to PTSD. Okay. The first is called dose, and that has several things in it. So the dose of trauma could be how bad was the trauma. I was almost killed. I was, hit by a car, and I was in the emergency room and in the hospital for 2 months, and I almost died. Is a different trauma than I stepped off the curb and got clipped, and I was terrified. So that's a different severity. The duration of the trauma is something that we're always looking at, and by duration, we're typically talking about window of time, not the duration in hours, but the window of time. I was physically abused for years versus there was a single event of physical abuse. Then the next one is age. I'm sorry, I keep struggling with wanting to go into a whole description of something called complex PTSD, which is thought to be slightly different. It is not a recognized diagnostic category in the DSM-5, and it is a recognized diagnosis in the World Health Organization. And it just has a more enriched set of variables that you think about in terms of coming up with that diagnosis. One of them is age of trauma, and in complex PTSD, you're usually having earlier onset and more multiple episodes of trauma, or more enduring and ongoing trauma. So I'll get back in my lane. We're just going to talk about DSM-5 PTSD for tonight. But age is a variable in whether traumatic events progress to PTSD or not. And that has to do with things like brain development at different ages and vulnerability of our neurobiology. It also has to do with age-related ability to contextualize events. So something that's occurring to me when I'm 6, I have zero context to understand what's going on. Whereas if I'm 16 or 26 or 56, there's a whole different set of variables that I can use to contextualize this series of events, which may make one of the things that may happen from that is that I'm less likely to have that be something that I understand to be about me, the more context I can have. And age is also then related to the impact on my developing sense of self. So 6 or 10 or 15 is different self-development and understanding of who I am as a human than it is as an adult. So social support is a big one in terms of whether this is going to progress to PTSD or not. The ability acutely upon those events occurring to access trusting relationships or receive kindness or understanding about what's going on, and the ongoing ability to access those kind of relationships. Both of those variables will impact the degree to which I, as the person having suffered the trauma, is going to internalize that and develop a whole series of negative cognitions around this event and negative understandings of this and predictions about the future. If I have less social support, I'm more likely to move in that direction. The trauma type, there's a lot of literature on this. I'm not sure that it's 100% clear actually, but the sense that interpersonal trauma, as opposed to impersonal trauma or like natural disasters, is more likely to cause PTSD. So that there's a trust violation and a sort of existential humanity violation occurring in certain types of trauma that's not occurring in a car accident or in an earthquake, which can increase the probability of it developing into PTSD. And then sort of hardwire, who am I? Literally just was having a discussion with somebody and hearing their history about childhood and how they were always incredibly anxious and always explosive as a little kid. Even they remember that's a type of temperament. It can also be induced by my environment and how I'm what world I'm living in. But there is such a thing as temperament and genetics, and that we all react differently to the world and to the stimuli in the world. So I may be more susceptible to have a more severe reaction to trauma than someone else. Okay. Okay, I'm glad you like the Zoom effect. So in terms of diagnosing this with the DSM-5, as I said, there are different diagnostic systems, but the American Psychiatric Association uses DSM-5 and includes these elements to derive a diagnosis. The reason this matters, by the way, a diagnosis, and there's a lot of debate about diagnoses being categorizing of people, and it's not really helpful in terms of understanding their functioning and so forth. There's some truth to that. What there is also some truth to is in this world of trauma and PTSD, as I said earlier, being able to distinguish between I've gone through traumatic events versus I have something that can be called PTSD because of an amalgam of symptoms that I struggle with, does actually help us in terms of treatment pathways to think, okay, you've been through trauma and it's difficult, but you don't actually have a series of frozen embedded reactivities that are associated with PTSD, where someone with PTSD does, and there are treatments that are very effective for that, which we wouldn't need to do or want to do with someone who didn't have PTSD. So it does actually matter. So the parts of the criteria for this in the DSM-5 are having been exposed to actual death or threatened death, like I thought I was going to die, or be seriously injured, or sexual violence. And that can be that it happened to me, I was direct exposure, or I heard or witnessed that happening to someone who I'm close to. So either one of those qualifies. Repeated aversive exposure means I don't necessarily think that I'm going to die, but I'm being repeatedly exposed to life-threatening situations, like I'm a first responder, and I have to constantly go out and be involved in situations where people are dying or injured in grievous ways, that kind of thing, that can also qualify as a trauma that leads to PTSD. Has to have caused significant impairment in my ability to function for at least a month. And then there's these symptom clusters that you need to have at least some of these symptoms in each of these 4 clusters, which I'll talk about in a minute. These are the 4 symptom clusters. So there's what are called intrusive symptoms. That's re-experiencing terrible memories, having terrible nightmares, having flashbacks, and having prolonged physiologic reactions to things that are occurring in the world, sort of and reliving these things as if they were happening now. And you can have different types of things that fit into that category. You have to have at least one of those occurring to be able to be diagnosed with PTSD. And it just sort of help let you think as you walk through these, like, what does this actually mean if you were experiencing this? Avoidance, at least one of these types of symptoms. And that's typically, I don't want to think about certain kind of memories. I don't want to experience certain kinds of feelings. I want to stay away from anything that reminds me of the trauma. And there may be a lot of actions around that that are going to keep me away from that. Okay. Negative alterations to cognition or mood. So that's really thinking badly about yourself, having lots of negative mood states, depression, hopelessness, sense of detachment, inability to experience positive emotions, lack of interest, feeling emotionally numb, those types of things. And then alterations in arousal and reactivity. That's irritability, anger, startle response, hypervigilance. I don't sleep well. I can't concentrate, that kind of thing. So again, this is a list of symptoms, and I'll put it up in a different way. Flashbacks, trouble sleeping, feeling alone, losing interest, having angry outbursts, feeling worried, frightening thoughts, that's the stuff they don't want to go to, trouble concentrating, physical pain, avoidance of all kinds of stuff. I hate that. I don't like to think about this. I don't remember things. I can't, foggy and stuff. I really don't like myself. I think I'm to blame for lots of stuff. I'm irritable, vigilant, and I startle easily. And PTSD means you have a bunch of these, not just one of them. So again, putting yourself in those shoes, not a good place to be. And people experience PTSD as awful. Typically, the types of things that are happening that are also then leading to the behavioral parts of this, the behaviors that are happening post-trauma are, I'm going into avoidance. I'm trying to stay away from emotional responses. I'm trying to stay away from routines that remind me of this. I'm not doing anything that's going to remind me of this. And then on an internal level, I'm going to walk through this idea of fear structures, but internally, there's the idea that my reactions and my emotions that were present during that, or could have been present during that initial trauma, they weren't necessarily present during that initial trauma, are things that I'm going over and over again in my head, so to speak, and that become further and further sort of ingrained and encoded in my memory. One of the concepts that's used is fear structure, which I'll explain in a minute. It's a made-up concept. It's not like a literal physical thing in your brain. It's just a way to think about the conglomeration of things that start to glue together, that we can think of in terms of our bodies, our somatic responses, our thoughts, our emotions, All of those things are part of this syndrome. Okay. So this fear structure idea is this idea that that PTSD is a memory issue, and that we have these blueprints that have been established related to the trauma, which include things like the details of the trauma. So I remember what happened and who and where it was. I have a series of physiologic responses, a racing heart, sweating, feeling numb, feeling cold. And I have a series of thoughts that are related to this I'm going to die. I should have seen this coming. I caused this, that get tied up into a fear structure that's related to this trauma that I've been through. So in the bottom here, we're saying in the context of developing PTSD, things that I encounter in my life after the trauma that are similar enough to any of the elements of this fear structure can activate this whole memory network. Okay. So example, I see someone who looks like my assailant. That would be an obvious one. There's all kinds of triggers, as they're often referred to, cues that can stimulate that fear structure to get kicked off. I have a racing heart because I ran up the stairs. That can kick off this fear structure because that's how I was feeling during this traumatic event. So any number of things can activate that. And it's not that the idea of fear structures is that they're pathological, because fear structures are a series of associative things that we've learned and put together that help us. So they tell us about dangerous things in the world. Oh, I'm getting scared. I should probably be vigilant. I should look around and understand what's going on here. And I have associations about things that occur that are dangerous in the world, and I need to pay attention to those. I'm seeing a bunch of people who are scary looking, and maybe they are scary. Maybe they are going to attack me. I should probably take in those cues from my learned experience. And flexibly use that information. Oh, I'm feeling afraid, but I can also think through the fact that these people over here are not actually scary because of X, Y, and Z reasons. Okay, so there's more flexibility in normal fear structures. It's an evaluative function that you can still exert around it. Okay. Wow, I'm driving fast. That actually is kind of dangerous for me. I should slow down. The pathological version of that is that the fear structures that get activated that are not helpful are the ones where there's this excessive amount of detail that's pouring in related to the current stimuli that aren't actually present, that are associated with past events, whether that's my physiologic reaction, my thoughts, my emotional states, and that those associations are not actually rational associations. It's dark out, so I'm going to be in danger. That's not actually a rational association. Could be true, but there's no truth inherently in that. I just have bad associations with nighttime now, because that's when I was assaulted. And those structures, a fear structure that is not helpful, that's related to PTSD, are much more rigid. And are hard to penetrate and modify in any way. So saying, don't worry, it's fine. There's nothing going on here. It's not scary out right now. That's like meaningless to someone with PTSD. Okay. There's our web. This is an example that we had from someone who had gone through this car accident. So the trauma for them was a car accident while they were rushing to get their kids to daycare. And they were suddenly driving into oncoming traffic. There was two-way traffic on a bridge, and they were having a fight with their partner, and they crashed. And one of their children died. And that's a terrible trauma. And that's doesn't necessarily result in PTSD, but in this case it did. And the post-traumatic behaviors that have then subsequently been activated that can be activated in any number of ways. So all these bullet points here are, you see them, some of them are in this web then, which is supposed to signify the web of the fear structure. You pull on that, and you can touch on one part of that web and the whole web gets pulled in. It reacts, okay? So I'm now, post that trauma, I am now not driving on bridges, and I'm numb in relationship to my partner because I associate my partner or even getting into a fight with a series of events. The music happened to be Bruce Springsteen, so I don't listen to that anymore, which could then generalize to other music. I don't listen to music in the car at all. I don't drive in the car at all. Or I have to medicate myself to be driving. I smell gas because that was one of the things that happened in the accident, and it makes me want to throw up. My kid being in a car, my other child being in a car with another person makes me panic. The idea that they would be driving in a car, and I'm not able to be affectionate with my other remaining child because I have this series of cognitions that I'm a horrible parent because I let this happen or I caused this to happen. Okay. Any number of these things could then stimulate that sense of reactivity, those sets of reactions in me. And so one of the things we're trying to do and there are many ideas about treatment of PTSD and what are the active ingredients of effective treatment, which we will not debate, but one of the more straightforward versions of this is modifying fear structures as a way to move forward. I was putting it here as making room for other experiences. As I said before, the idea of the fear structure is that it's very rigid. So I saw a bridge now, I'm driving and I'm like, oh my God, I gotta have to drive across a bridge. And now I'm in a full-on panic and my heart is beating and I want to throw up and I'm terrified, okay? There's no room for anything else there in my intrapsychic experience at that moment. So the goal of a therapeutic intervention would be, how do we help loosen that? How do we help there be, you might still be having that sense of fear, but is there room for more in that room with you other than just that one thing that's dominating your emotional states and your behaviors now also? I'm not driving on bridges anymore. Bridges are dangerous. That's what I believe now as well, okay? So the idea of exposure is a part of many trauma therapies, which we'll get to, which is, can we, in a gradated way, start to have you encounter some of these things in that fear structure and allow yourself to experience them and come out the other side and start to learn something new, which is that I can actually experience some of these stimuli and not have it result in what it resulted in previously. Because that's what I think is going to happen. That's what my body is telling me is happening. That's what my emotions are telling me is happening. The worst possible thing is going to happen again because I'm going to drive over a bridge. And can we expose people to the things that are scary for them and allow them to experience it in new ways over time? Okay. So we're modifying those rigid elements of the fear structure, which over time, I'm learning new things. So the negative trauma-related cognitions aren't the only thing that I'm able to think. And interestingly, when you're doing exposure-based treatments in a therapeutic setting, there's a titration of how much is tolerable or not, but the greater the fear activation in the therapeutic setting, the greater reduction ultimately in my PTSD symptoms I'm going to have, which on a logical level makes sense. Like I'm able to experience even really a big activation of all this stuff and come out the other side and nothing terrible happened. And I can learn now, even when I'm really activated, that it's actually going to be okay. And there isn't only one outcome that's going to happen here. So I'm able to have more flexibility about what actually is danger here. What is danger in the world? We're not eliminating danger in the world. We're not painting a good picture of the world. The world is a dangerous place. But we are saying the world isn't only a dangerous place. And if the world is only a dangerous place to you, which is what it is when you have PTSD, your world is very small, okay? So we can start to have some fluidity amongst in those physiologic reactions, those emotional reactions, and in our cognitions as well. So the example we have here is a transition from I caused this to I'm a parent who was in a terrible accident and lost my child. That's terrible. But I can love my other child because they still need me. Okay. So I have more flexibility in my humanity at that point. Okay. Let me just see where we're going here. Okay. And that last slide, do I know how to go backwards? I don't know how to use the slides anymore all of a sudden. I don't know why. But as with substance use issues, a lot of people are not getting help for PTSD. Most people, 2/3 people don't get help with PTSD. Even veterans who have access in the VA now, and the VA systems, despite all their problems, have incredibly good trauma treatment programs. Still, only about half of veterans with PTSD get treatment for it, for all kinds of reasons. But so let me just pause for a second. It's 10 to 8. So I'm only going to pause for a little bit. Any thoughts? Anybody want to shout out anything or questions so far? I can just keep going too, but the fun stuff is, well, that was not the fun stuff, but it's interesting to talk about the treatment stuff of this too. Lori.
So I do have just a little bit of questioning, I guess. I'm just trying to understand, that's all. Because I'm not a social worker. I haven't been through training or anything like that, but I'm really trying to understand what you were talking about tonight.
Yeah.
And so what I think I heard you say was that we're not necessarily talking about the trauma specifically, but more the response by the individual to their trauma.
Yeah.
Okay. And okay, that's basically it. Okay, thank you.
You nailed it, you non-social worker. Other thoughts, questions so far? Yeah, so what we've been talking about is traumatic events, bad things happening in the world happen constantly, and happen to almost all of us. Often we don't get PTSD from those. It just doesn't make them nice things to have happen to us, but PTSD is a different animal. And there are things that help not go into a PTSD state, and things that would be more likely to actually allow that to progress in that way. Okay. Let me go back to my weird screen. Okay. It is hilarious. Not the slides, the little picture of me. So we talked about the rates of substance use disorder and then the rates of PTSD. And then there's this overlap, and what is called comorbidity is the technical term for the co-occurrence of two different psychiatric disorders. And actually, it's not just psychiatric disorders, it's anything, but comorbidity is what we're talking about here with substance use and PTSD specifically. And how often does that happen? And the answer is a lot. So, and these numbers are all over the board. So we probably sort of take a middle ground here, but 29 to 79% of those who have PTSD will have a substance use disorder. 79% I think is high, but we can take it down the middle and say it's 54%. So approximately half of people who have PTSD will also have a substance use disorder, which would be good to know if you're a PTSD clinician, right? But I should be thinking about that as well. The other version of that is that anywhere from 14 to 60% of people with substance use disorder have PTSD. So this is back to that question earlier about is all substance use around trauma and PTSD? This would say no. again, lots of us have trauma. So if you included all trauma, then you're getting into a much bigger number in terms of people who have substance use issues. Lots of people have trauma, but in terms of how many people have PTSD, I think of typically, and I'm not going to show these slides, but we did assessment of 1,200 people who came into our outpatient program over 6 years or something. I forget how many years it was. And when you do a screen of those people with a PTSD measure, which we do, about 30% of those people met criteria for PTSD by self-report. In an outpatient, in a group of people coming in saying, I have a substance use issue and I want outpatient treatment. So that's a lot, a third of the 30% of those people. In our inpatient program, with a group of like 600 people, that's a lot also, the rate was more like 40%. So what you see is as the substance use severity increases, so does the likelihood of PTSD. Right. And the slides, it's like a flip deck. You know those slides you had when you, like a little book you had when you were a kid, you could flip through them and you see a guy running across the page, like if you do it really quick. I have a set of slides of like 10 slides of different psychological measures: depression, anxiety, psychiatric distress, substance use consequences, all this kind of stuff. And literally, if you categorize self-reported trauma, PTSD symptoms on one axis and go, the higher we go on this, the more PTSD symptoms I have. Every other measure goes up. Literally every other measure goes up with the PTSD symptoms. Meaning, if I'm higher in PTSD symptoms, I have worse depression, I have worse insomnia, I have worse anxiety, I have worse substance use consequences. Every category. It's striking. We show that slide to physicians, psychiatrists, and ASAM docs because we want them to understand that when people are sitting in front of them, if they're reporting PTSD, they have a ton of other stuff going on with them as well. It's not just PTSD. And that people with PTSD are 6 times more likely to develop an alcohol use disorder than those who don't. And 20 to 65% of people in treatment for substance use report having assault histories. So what's the association between those things? And this is a very brief discussion of that. Like what's leading what, chicken and egg, what's going on here? Several different theories: self-medication hypothesis, which is PTSD may cause substance use disorders because you're medicating the PTSD symptoms away with your substance use. And in fact, most so the next one is a high risk hypothesis, which is their substance use issues are exposing me to high risk behaviors and then traumatic events, which then cause PTSD. There's the susceptibility hypothesis, which is there's an underlying sort of like biological vulnerability to both of these disorders, like temperament issues. And the winner is closer to the first here, that over and over again, studies are ending up suggesting that PTSD often has a causal role. So if I have PTSD, it may be leading to substance use disorders, which does not mean that all substance use disorders are caused by PTSD. It just means that that's the direction of it, that substance use disorders don't cause PTSD. But when we look at this group of people in that Venn diagram that we just showed before, this is a much worse off group of folks. So if I do have both of these things on board, I'm doing much worse in lots of ways. Physical problems, other mental health problems, higher suicidal ideation, more suicide attempts. I'm using healthcare services and psychiatric services at a much higher rate. And I have lots of other sort of functional impairments. My relationships, my employment history is just poorer if I have both of these diagnoses. And in terms of my treatment, I do know how to go back. In terms of my treatment, if I'm someone walking in with both of these issues, I'm more likely to drop out of either one of the treatments that you might offer me or the co-occurring treatments. And I'm more likely to go back to using substances quickly. Cordelia Kraus.
Okay, got a question in the chat that I just wanted to point towards, if that's okay to highlight.
Sure.
Karen says, sorry if this is a rookie question, if the vast majority with PTSD aren't seeking treatment, where are those PTSD statistics coming from? Same thing goes for addiction. With plus or minus 10% of people with SUD seeking treatment, how do we really know about how many people are affected by it?
We only know that from well, we know it from epidemiologic data somewhat, and we know it from treatment studies. And one of the problems, so it's a great question. One of the problems in even understanding these phenomenon are that, which I'll get to in a little bit, but that in research studies, randomized controlled studies, often what you have when you're doing randomized controlled studies with substance using folks is they exclude people with PTSD. Or if you're doing studies on PTSD, they exclude people who have substance use disorder. Isn't that convenient? So you don't even get to look at questions of prevalence if you're saying you're not in part of the study anymore. But there is epidemiologic data to look at in terms of population prevalence. And there are studies that have been done with people with co-occurring treatments. So there are small bits of data on this. Okay. So what would we like to do, just to jump the gun here? Ultimately, what we'd like to do is something that's called lots of different things, but integrated treatment, I think, is the one that captures it best, which is treatments that are looking at helping both of these struggles at the same time. There's sequential treatments. We're going to treat your PTSD first, and then we're going to treat your substance use, or vice versa. There's singular treatments where we're only going to treat one of those, and good luck with the other one. Integrated treatments are saying we're going to do them both at the same time. And when we do that, and I'll talk about what some of those are, we're more likely to help with the PTSD, and more likely to not have people fall back into PTSD symptoms than if we just do substance abuse treatment alone. I'm not sure what that next bullet point means, actually. I don't know why I put that in there. But when we're able to do integrated treatments, we're better able to keep our eye, obviously, on managing the PTSD symptoms. And when we're able to do that, we're able to reduce the substance use risk and likelihood of relapse. Then if you treat PTSD symptom change mediates changes in alcohol use. So if you are getting changes in their PTSD symptoms, you are then in these studies finding changes in substance use as well. The big fear has always been, and I'll get to this in a minute too, that we're going to cause relapse if we start to treat PTSD in substance users, and that has not been found to be true. And if we're doing treatment in a co-occurring way, we're having a much lower relapse rate to the PTSD symptoms over time. Okay, enter our elephant again, who is wanting us to ask the question, what about those? So what about those great integrated treatments then? So this is the bad news. The one I just mentioned was that if you look at randomized controlled trials where we're looking at treatments for substance use or PTSD, the number of studies that have kept those separate and excluded the other is the vast majority. There's a much smaller number of studies that have included people who are struggling with both of those. We also have other issues like traditional recovery, substance use recovery approaches, having sort of myths about how you can approach these things. And one of them is that you can't address trauma until you've had sobriety for a year. and people have repeated that to me more times than I can remember in my career. It's just a concept that's been made up. In mental health treatment programs, if I went in to get treatment for my PTSD, often I'm going to be told, we're not going to treat your PTSD. You need to address your substance use first and then come back and we'll work on that, which again is a terrible thing because my PTSD is driving my substance use, right? That's what we were just looking at in the previous slide. And then addiction treatment programs often say, we don't want to touch your PTSD because it'll kick up all this negative emotion and difficulties, and then you'll relapse. So the bottom red line there is people with substance use disorders are mostly not treated for PTSD and vice versa, even though there's a reciprocal relationship between those two things. And then in traditional programs, you're also having problems like we're using 12-step concepts to explain symptoms that really might be related to PTSD. So I'm having relationship issues, and we're explaining those with these sort of like preset ideas of codependence or love addiction or these kind of things. My substance use is being explained as denial, or I need to bottom out. And my recovery is just this sort of black and white version of the things I need to do, as opposed to I have a very, very challenging set of internal experiences that are related to my PTSD, which are causing relationship issues, which drive my desire for any number of reasons to use substances, and which would require a much more nuanced and intensive treatment than just going to meetings. So there's a lot being missed there if that's the only lens we have. And then another thing that can happen in treatment programs is that even if we're using evidence-based treatments, and some of those I'm going to talk about in a minute, where often programs are using those in a non-evidence-based way. So you can take an evidence-based treatment and ruin it pretty easily by it's a 15-session protocol, and we just do 5 because we just want to give you a sense of the treatment here, and then you walked out thinking you got treatment for PTSD, and you didn't. Or we do it in a group here because we find that to be more effective, even though every clinical trial was done as an individually oriented treatment. So that's doing it in a group is not an evidence-based approach anymore. Doing it in 5 sessions instead of 15 is not an evidence-based treatment for trauma anymore. So, and then another big one is just this stuff is hard to do. These treatments take a lot, and so you really have to train people. You have to supervise them. You have to supervise the supervisors. It takes a lot, and that's not always something that programs can do. Okay, so a couple different buckets of treatment types for PTSD. This is not talking about the co-occurring treatments yet. I'm going to talk about this in 1 second, but just to put it in 2 broad categories, there's what we would call stabilizing and coping strategies, treatments, and then there's process and trauma-focused treatments. So in the stabilized coping version, that means we're looking at the symptoms of the PTSD and trying to help you cope with those, and have present moment focused strategies so you can not be ruminating about terrible things in the past. We have grounding strategies so that you can feel less physically panicked. We have, breathing strategies. We have cognitive strategies to push back against your cognitions that say that you're the worst person in the world. Those kind of things. Distress tolerance strategies. So there are a variety of different treatments in this category. DBT would be one of them, dialectical behavior therapy. It is a series of ideas that help people deal with a lot of distress and not go off the rails. Another one I'm going to talk about in a minute that's related to substance use is something called seeking safety. That is a way of being aware of the symptoms of my PTSD and finding ways to act more safely. So that's one category. The category on the other side over here, the processing of the trauma, is much more what we would call exposure-based treatments. And that is what I was referencing earlier about if we step into these fear structures, if we step towards these things that we believe deeply in our hearts and our bodies to be true and terrible, and allow ourselves to experience them, and come out the other side, we're exposing ourselves to that fear and allowing it to diminish. So that will be the other set of trauma approaches, of PTSD treatment approaches. And you can do that through somatosensory things. You can do cognitive processing therapies. You can do EMDR, which is a strange mixture of things, which is in essence, however, an exposure-based therapy where we're talking about the trauma. You can do prolonged exposure therapy, where we're explicitly talking through the literal trauma that I experienced, okay? So those would be on that side of the equation. So what do we find? And I just talked about some of those. But just to say briefly, there are a list of evidence-based treatments. There's not a long list of treatments that have been shown to be very effective for treating PTSD. Prolonged exposure is one of them, where you're literally walking back through the experience that I had and talking about it over and over again out loud with a therapist. And you're doing what we would also call in vivo exposures. So in your life, you're going out then and sitting in a movie theater, even though it's terrifying to you, or you're going to a parking garage where you were assaulted because it's terrifying. You're re-encountering those fear structures and those fearful things as a way of getting to the other side. EMDR is another one, which has to do with bilateral stimulation of the brain and exposure to the fear structures within that context, which for mysterious reasons seems to help resolve that level of fear and is quite effective. Cognitive processing therapy is another one, which is more cognitive and more challenging of negative beliefs and understanding how I'm thinking about this and coming up with a different set of cognitions around these fearful experiences I've had. A newer one is written exposure therapy, which has also actually been shown to be quite effective, has not been tried with substance users at this point yet. Not in a randomized controlled trial at least, and is a much briefer therapy and is more about writing out a narrative of my trauma. But then in that sense, it's still an exposure, right? I'm exposing myself to the stuff I don't like to think about. Because again, back to the symptoms, one of the major symptoms of PTSD is avoidance. It's like the hallmark symptom of PTSD. I don't want to think about it. I don't want to feel that. Don't make me go there. Don't make me think that. Don't make me feel that. Don't let my body feel that way, because it's terrible and it's overwhelming. And I'm going to do whatever I can to avoid any of those things. So all of these exposure-based therapies are saying, could we invite you to walk towards it instead of away from it? I was referring to that before. I was making room for that, right? Making room for new experiences, despite the fear that I'm having, okay? So these are for PTSD. What about the people we've just been talking about in our Venn diagram, PTSD and substance use, both? What are we doing there? So I'm going to talk about an exposure-based version of that very quickly. I'm going to talk about the non-exposure version of that. The ones on the right are the exposure-based ones. The ones on the left are the stabilized coping ones. So prolonged exposure was then combined with relapse prevention, cognitive behavioral therapy for substance use disorder, in something called COPE, which is concurrent treatment of PTSD and substance use disorders using prolonged exposure. Somehow that gets put into an acronym, COPE. It's a good acronym though. And so there's some psychoeducation in there about common reactions to trauma, which is what you would have in a lot of trauma treatments. There's a attention to cravings and thoughts about using alcohol and drugs. There's a connection made between the symptoms of my trauma, my reactivities in my PTSD that lead me to have more cravings and thoughts about using. So there's connections that are made there, and we're doing the exposures that we would do in a prolonged exposure therapy as part of this treatment also. So we're putting all of that stuff in the same room, not every session, but we're doing that over the course of, I think it's 16 sessions, but I can't remember. Might be, I don't know what it is, but anyway. And so that's an exposure-based integrated treatment, right? We're not ignoring your substance use. We're talking about it throughout this time that we're doing this exposure-based treatment for substances, for PTSD, okay? Order after 8. Seeking safety is the stabilized coping one. We're not doing processing of your literal trauma. It's a cognitive behavioral therapy, and it's incorporating relapse prevention also, interpersonal skills to navigate the world in a more functional way. We're talking about my substance use, and in the same context as talking about the traumatic experiences that I've been through. But we're not talking about we're not revisiting the trauma in this type of a therapy. We're saying, and how does my trauma come out today? Oh, I get really afraid of stuff, and that makes me want to go drink. Okay, we're going to put those in the same room. Well, I'm not asking you to walk back through what you were afraid of originally and what that trauma was and how that got stuck in you in a fear structure. I am asking you to talk about it now, like what happens today when that happens, okay? So we're acknowledging the trauma throughout the treatment, as opposed to ignoring it entirely. And this is a fairly widespread protocol that's used around the country, actually, seeking safety. Partly because it's pretty easy in terms of the heaviness of the lift of training people. It's an easier one to train people in. It's just easier. Exposure-based treatments are a heavier lift in lots of different ways. But when you look at these two head-to-head, what you get with COPE, the exposure-based one, is you really lower PTSD symptoms. You really get a big impact on people's PTSD. And when you have the impact on PTSD, you have greater reductions in the substance use issues. I'm not sure why it says does not result. Oh, it does not result in increased substance use, right? Which is always put into these things because that's the big fear. Oh, if we do that really scary therapy, exposure therapy, is people are going to start to use more. Which there's some logic to that, but it doesn't turn out to be actually true over the course of a whole therapy. Some of the issues with it are it takes a long time. These are like 90-minute sessions, and people drop out because people drop out of exposure-based treatments because they're hard. Seeking safety is not so hard. It's less challenging emotionally, and you get less improvement. Remember what I was saying before about if you get more activation in an exposure therapy, you're going to get a greater reduction in the PTSD symptoms. The more challenged I feel in my session, the greater my reduction of my PTSD symptom is going to be. So in a treatment that's not doing that kind of challenging of my PTSD process in that way, what you find is I still have symptoms of PTSD. I think you have lower dropout rate from this kind of treatment protocol, which is a real benefit for sure. But I still have PTSD somewhat at a higher rate than if I did COPE, okay? And essentially I get the same amount of reduction of my substance use as I would with a treatment without this. And people like it a little bit more because exposure therapies are not fun, okay? I'm going to skip that. So I just wanted to say that those are two sort of different worlds of integrated treatments. So I hope that made sense. One is the sort of the exposure-based stuff, and one is the non-exposure-based stuff. But we're in both of them, we're bringing substances and PTSD into the same room and talking about them. It's just we're going slightly different places with them in the exposure-based one. Okay. So I want to get to another part of this. So the challenges of doing these integrated treatments, there's very literal challenges. It's harder on the staff. We have to train them more. It takes data collection as part of the treatment process with these treatments. We have to have clients do homework, which people don't like to do. It's tough on the clinicians at times. It takes more supervision, and it's labor intensive. Okay. And there's a other side little issue of there's been a number of studies suggesting that it's more effective if you're going to do an integrated treatment to not demand abstinence from people, because that's just a high bar that's going to actually expel them from treatment. To say you may struggle with substances throughout this, we're going to keep working at them. We're not ignoring it. We're going to keep working at them, but that may happen as part of this integrated treatment. That idea makes an abstinence-only program a tough place to try to do integrated treatment, right? If we're saying integrated treatment is going to go better if we don't insist on abstinence, and then this program is insist on abstinence, we got a problem. So, okay, some more elephants. I love those guys. So, finally, to our family, families are also having all kinds of reactions with someone struggling with PTSD, as we do with someone struggling with substance use. So we feel sympathetic towards them. We feel badly towards them. We want to avoid them, and we want to avoid the things that they want to avoid. There's increased depression. There's increased anger and guilt. There's increased health problems for family members. I'm saying this sounds familiar because this is a list that we would have for substance use families too, right? And these are the kind of things that people are going through: feeling hurt, alienated, discouraged, because and PTSD has historically been thought of as this very sticky thing that no one ever gets over. That's not true anymore. It's just flat out not true. But we didn't have treatments for this 30 years ago. We really didn't. And I remember in graduate school in the 80s, it was like, well, PTSD, that's the worst because you can never get over it. Like, well, then we came up with a bunch of treatments that actually are quite helpful. But there is that pull to devote yourself to that person and try to help them and neglect your own needs. And there is the ingrown version of this, which we're not getting social support, which we really need. And we need to take care of ourselves, and we're not. All of that same stuff that we've talked about with the invitation to change, right? How do we pay attention to ourselves? So what I thought we could do, I wanted to take time to say, okay, let's think about this PTSD stuff through an ITC lens. But I'm just going to walk through an ITC lens for a little bit, and then we can talk about it. So remember this one: the behaviors make sense. If I could help you feel blah, 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 all these things, remember that one? So how do we apply that to PTSD? Because remember the punchline to this series of questions was, it's called alcohol. Here it is, right? So a couple of ways to look at this with PTSD. One is, boy, if it made sense before, it really makes sense now. Because if I have PTSD, here's what it's doing for me. Here's my list. Here's what heroin does for me. Keeps me in my body when I'm asked a question by a stranger, which otherwise I'd be completely dissociated. Helps stop my racing thoughts that I might hurt somebody. Numbs the intensity of these flashbacks about being sexually assaulted. Helps me not shake in public. Helps me pretend that I don't feel scared all the time when I'm drinking. Helps me feel less disgusted about myself. Helps me get out of my house without a panic attack, which is what I have with my PTSD. Helps me stay calmer instead of just exploding at people in my life who I love. Helps me sleep, even though I'm drenched in sweat typically from my nightmares. I don't want to kill myself when I'm drinking. Helps me get out of the house at all. Helps me not hate myself a little bit. Helps me feel brave enough to make eye contact. Okay. If I don't have this substance, I may have a lot of these things. And these are terrible. This is the behaviors make sense part of substance use, right? With PTSD, the co-occurring disorders. This is just my world and what substances do for me. My world as somebody with PTSD. So there's another way to think about it also, which I just think in terms of this helping with understanding part about behaviors makes sense. It's just to look at it from the lens of the PTSD itself, the literal symptoms the literal behaviors I engage in that are my PTSD. But my PTSD is a reaction. It's a protection for me. My drinking is a protection for me here. It helps me, right, with all these things, right? My drinking here helps me with all these things. My drinking with my PTSD helps me with all these things. My PTSD actions also help me. So the numbness I have helps me not experience this terror. The avoidance of not going out of my house helps me not experience this terror. The breaking off of relationships makes me not come up against this. So we can look at those behaviors and go, what is the matter with you? Why, just like, there's nothing to be afraid of. Come on, let's go to the mall. It's okay. Get over it. Like, you've been talking about this, right? No, those things I'm doing are protecting me, just like my drinking is protecting me. Okay. Just like my drinking has a downside, which is why I'm sitting in this office talking about my drinking, my PTSD symptoms have a downside. I can't go out of my house, and that's not a good thing, but it's good in the moment. Just like my drinking is good in the moment. It's keeping my panic lower, okay? So again, as with the ITC for the substance use behaviors, this is helping the helper, us, having an understanding of these experiences that the person with PTSD is having, have more empathy, the dog in the road, stepping towards them instead of stepping away, not taking it personally, that you're not able to go out with me, that you having a panic attack when we were just having dinner. I don't know what's going on here, what's happened here, which makes me want to collaborate with you, which makes me understand, oh, these are the things that trigger you. Okay, I can help with that, right? And it helps them by feeling, which again, same with substances, but boy, you get this when you talk through common reactions and symptoms of PTSD with somebody who has PTSD. They just want to hug you. They're like, no one ever told me this was PTSD. No one ever validated that this is my experience and that there's a name for it. I thought I was crazy. I thought I was just crazy. And now I can be more open about this because you seem to understand what's going on here, right? So that's where we would want to bring in the ITC, and I think apply that framework. How does helping understand your behavior and what you're going through help me help you? How does helping understand the specifics of your PTSD help me with this? How does it help me understand your ambivalence about even going to the doctor's office because it's terrifying, And then over here with the awareness, it's going to be really important for me to be aware of my own reactions because you act in ways that I don't understand sometimes, and you act in big ways at times, these big reactions and panics and different things that I don't understand. So what about my willingness to engage here? Those same questions are going to be part of this, right? So I think it's going to be fruitful for us as a group to talk through this over time, but I'll stop there. And just, we have 1 minute.
There were a
Talk
couple
fast.
questions in the chat that you should check out.
Okay, what would those questions be? Anybody want to raise their hand and ask those questions? And we can go a little bit longer for sure. And people certainly can feel free to leave if you need to or want to. Cordelia Kraus.
Okay, so one of the ones I think we're going back on, do you have any specific recommendations for clinical training for prolonged exposure, EMDR, seeking safety, COPE?
Yeah.
And while you're thinking, if I didn't ask that, Lori, jump in and re-ask it in a way that that has the heart behind it that you wanted.
Depending on what, if you're part of an institution, sometimes they provide these trainings. Like if you're part of the VA, they do all kinds of trainings with people in prolonged exposure, I think cognitive processing therapy. I'm not sure if they do EMDR in the VA yet or not, but they do all kinds of stuff in the VA. They're starting to do MDMA trials also for PTSD. So sometimes you can get it through professional circumstances like that. I know a lot of people in our group years and years ago were trained in prolonged exposure down in Philadelphia, University of Pennsylvania. The person who developed prolonged exposure is a woman named Edna Foa, a psychologist in the late 80s and the 90s. They still do trainings there. It's like a 4 or 5 day training. There's other groups that do trainings in prolonged exposure around the country. So you can just go and get trained in it and take the 4 or 5 days. Same with EMDR. You can go to sign up for an EMDR training. It's pretty extensive. My experience is that people do like 3-day weekends, 3 of those to do preliminary, and then they get supervised, and then they come back 6 months later and do some more training. So it's a lot. People find it really interesting training. As a side note, the prolonged exposure people and the EMDR people all hate each other just because, we're all human beings and territorial, but they're both really good treatments, and they're both evidence-based, successful treatments for PTSD. But they just shit talk each other all the time. Seeking safety, you can buy the manual for seeking safety, and anybody in this room could buy that manual and read through it and then do it. Because it's pretty straight up cognitive behavioral relapse prevention therapy with some bells and whistles to acknowledge trauma, but it's not particularly complicated, which is one of the reasons it's actually it's more easily incorporated into institutional settings, which is a good thing. It just, as I said before, it's less effective. So it's sort of weighing the two different parts of that. Okay. Other questions, thoughts, reactions? The bad news is this stuff really isn't available. I mean, it's like when we started talking about craft 15 years ago, like no one had ever heard of craft, or doing anything that was helping families. And by the way, what I just walked through was about PTSD and substance use for the person who's struggling with both those, not the families. So is there a protocol for the families? No, there is not. That's why we're going to develop one. But that's why we're trying to think about how does the ITC, is there an offshoot, for how do I help someone with PTSD or PTSD and substance use stuff? Like how do I sift those two things together and have a great understanding and use these same tools in the circle,
I'm just wondering a little bit about, so we're talking about treating PTSD alongside of substance use disorder. And I wonder what the role of, I'm just kind of thinking of like the Sinclair method and adding in this piece of medicine and how helpful, and then Cordelia, you in the chat box started talking about, well, and I guess, Jeff, you did too, talking a little bit about that harm reduction piece and how it could all be incredibly supportive of one another.
Yep.
Yeah, I don't know, just kind of thinking out loud, I guess.
Yeah, I mean, it's like if we applied harm reduction ideas, which harm reduction, as we've talked about this some before, harm reduction is in essence a very motivational approach. Or you could put it another way, you could say inherently motivational approaches are harm reductionistic, meaning that phrase like starting where they're at. Well, starting where someone's at means I'm not stopping substances. So that's not an abstinence approach, right? If I'm going to actually start where you're at, you're saying I'm not stopping. Maybe I'll think about this, but that's where I'm at. Okay. That's what starting where you're at really means. And that's a very good thing to do, motivationally speaking. That will pull that person in. But that's an approach that's also effective because I'm not insisting on some outcome that is more important that is more my outcome than the one you want at the moment, and that you might not actually be able to just do right now. With PTSD, this is not a like, okay, we've now pronounced you with having his PTSD, we're going to do this thing, and now you don't have those symptoms anymore. It takes time. It takes work. Like, we don't expect abstinence from PTSD symptoms, right? I'm still struggling. And I had completely freaked out last week. I don't know what triggered me. And I went ballistic because I thought, blah, blah, blah. Thought someone was chasing me and they weren't, Okay, because you have PTSD. And then you relapse to drinking because you have substance use disorder. Okay, that's what we're doing for this all for. That's why we're here together, working on this stuff,
And I'm wondering too, like the Americanized version of the Sinclair method, where they're giving people like the Vivitrol shot for alcohol use. And there seems to be like this lack of understanding, even on the medical professionals side of it, that Vivitrol is supposed to help some, excuse me, sorry, got a bad cough.
Sure.
Help someone to be abstinent from drinking. And I mean, I've talked to families and I hear of like people being kicked off of the Vivitrol shot. Oh, it's not working. 6 months later.
Right.
And I'm like, well, how do you know, how do we know this? Right? Like what does this mean to be working and not working? And what's the doctor's philosophy on this? And is it, I don't know, just again, thinking out loud.
Yep. Well, that's whole other discussion about medications, but right. The Sinclair method in terms of naltrexone or Vivitrol, is essentially should be thought of as a harm reduction strategy. It's reducing. It's a good moderation medication. But if you don't think in moderation terms, it's why would you think about that medication? So. Any other PTSD thoughts? 25 messages. Has seeking safety ever led people to go further into cope? I don't have any idea. It's done so few. It's done so few and far between. All of these things. It's like hard to find people who are doing cope at all. A little less hard to find people who are doing seeking safety. But I think often like people who are doing seeking safety don't know anything about cope, so they wouldn't refer someone on, which is not helpful, right? Okay. Any other thoughts, reactions? Okay. Well, we are at the end of our time. Appreciate seeing you all. Nice to talk with you all. For those of you in that level 1 certification, we'll see you next Wednesday. For the rest of you, hopefully we'll see you in the monthly meetings, either Dia's or the other one, the competitor. And we'll see you next time.